Hello and welcome to the topic Polycystic Ovarian Syndrome in the Endocrinology module. By the end of this topic, you should be able to define Polycystic Ovarian Syndrome or PCOS, explain the pathophysiology of PCOS, outline the causes and classifications of PCOS, describe the clinical manifestations of PCOS, outline the investigations done and discuss the principles of management of PCOS, and finally discuss the complications and prognosis of PCOS. Let's get started. Polycystic Ovarian Syndrome or PCOS is characterized by hyperandrogenism, irregular ovulatory cycles, and a metabolic derangement which includes glucose intolerance and hyperinsulinemia. Polycystic refers to the numerous cysts present in the ovary which can be appreciated through ultrasound. Now, let's discuss the pathophysiology of PCOS. This diagram illustrates the pathophysiology of it. There are many proposed mechanisms of PCOS. They are hormonal imbalance at the hypothalamic pituitary ovarian axis, insulin resistance, genetic, and obesity. The increase of luteinizing hormone to follicular stimulating hormone ratio and hyperinsulinemia suppress the follicular maturation, which then causes chronic anovulation and polycystic ovaries. Besides, high LH stimulates stroma and thicker cells to increase the level of ovarian androgens. This results in hyperandrogenism such as hirsutism, menstrual abnormalities, and insulin resistance, which also causes hyperglycemia, type 2 diabetes mellitus, and acanthosis nigricans. This slide looks at what are the potential causes of PCOS. So this includes genetic in origin, intrauterine exposures, obesity, environment or lifestyle factors. Obesity increases the aromatization of adipose tissues, which worsens the pathogenesis of PCOS. Adipose dysfunction also continues to the development of glucose intolerance and hyperinsulinemia. This can exaggerate the manifestations of hyperandrogenism. The exposures to testosterone in utero may also predispose the patient to the later development of PCOS. Sedentary lifestyle is associated with increased metabolic dysfunction, whereas weight gain is associated with oligoanovulation and hyperandrogenism. Now let's take a look at the clinical manifestations. The common symptoms of PCOS are acne, increased facial hair, infertility, miscarriage, oligomenorrhea and amenorrhea, and also symptoms of diabetes such as polyuria and polydipsia. As for the signs, you would expect one to be obese, have signs of insulin resistance such as acanthosis nigricans, virilizing signs such as male pattern balding or alopecia, increased muscle mass, deepening voice, and clitoromegaly. There also will be evidence of hypertension. Other signs could also include signs of hyperandrogenism as mentioned earlier. So these are hirsutism, acne, oligomenorrhea or amenorrhea, and acanthosis nigricans. PCOS can be diagnosed according to the Rotterdam criteria. Patients that present with any two of the following criteria are said to have PCOS. The criteria are signs of hyperandrogenism, ovulatory dysfunction, and polycystic ovaries, which are noted through the ultrasound. Investigations can be done to assist physicians to diagnose PCOS. PCOS patients has raised serum free testosterone and serum androgen levels. Serum androgen level is measured when serum total testosterone is more than 5 nanomoles per liter. Transvaginal ultrasound is used to visualize polycystic ovaries. More than 12 follicles are seen in the ovary. That is considered significant. Sex hormone binding globulin in PCOS patients may also be normal to low. Among the lab tests that can be done include free androgen index, luteinizing hormone or LH, and follicular stimulating hormone levels or FSH. Patients have high LH with low FSH levels. Oral glucose tests and thyroid stimulating hormone tests can be done to look for hyperglycemia and to rule out other causes of amenorrhea respectively. Other than diagnostic investigations, there are some bedside tests that can be done, such as capillary blood glucose to look for hyperglycemia, a urine dipstick to look for glycosuria, and ECG as cardiovascular diseases are complications of PCOS. A transvaginal ultrasound is the best imaging study to diagnose PCOS. 12 or more follicles measuring 2 to 9 millimeters is diagnostic. The appearance of the polycystic ovaries give a pearl chain pattern on ultrasound. Ultrasound also can be used to rule out other causes of infertility. The mainstay principles of management for PCOS are lifestyle modifications, treat the symptoms and biochemical abnormalities, as well as return fertility. Medical management of PCOS is aimed at the treatment of metabolic derangements, anovulation, hirsutism, and menstrual irregularities. The use of insulin-sensitizing drugs to improve insulin sensitivity is associated with a reduction in circulating androgen levels, as well as improvement in both the ovulation rate and glucose tolerance. On the other hand, surgical management of polycystic ovarian syndrome is aimed mainly at restoring ovulation. Laparoscopic ovarian drilling is a surgical treatment that can treat ovulation in women who have polycystic ovarian syndrome. Besides, various laparoscopic methods include electrocautery, laser drilling, and multiple biopsy have been used with the goal of creating focal areas of damage in the ovarian cortex and stroma. Potential complications must be considered as well, and these include formation of adhesions and ovarian atrophy. Now, this image shows the intraoperative images of ovarian drilling. On the left is a laparoscopic image of the pelvis before the drilling procedure. The center is the drilling procedure, and the right is the ovary after the drilling procedure. Complications of PCOS are mainly fertility-related, which include infertility, gestational diabetes, pregnancy-induced high blood pressure, miscarriage, or premature birth. Evidence suggests that women with polycystic ovarian syndrome may be at increased risk for cardiovascular and cerebrovascular disease. Women with hyperandrogenism have elevated serum lipoprotein levels similar to those of men. Now, in summary, polycystic ovarian syndrome or PCOS is a constellation of hyperandrogenism, polycystic ovaries, and menstrual abnormalities. Genetic, obesity, sedentary lifestyles are known risk factors to this condition. We diagnose PCOS according to the Rotterdam criteria. The presence of two of the following criteria are diagnostic: signs of hyperandrogenism, ovulatory dysfunction, or polycystic ovaries noted through the ultrasound. Medical management of PCOS is aimed at the treatment of metabolic derangements, anovulation, hirsutism, and menstrual irregularities. The complications of PCOS include infertility, hypertension, and pregnancy complications. Last but not least, PCOS patients may be at risk for cardiovascular and cerebrovascular diseases. We have come to the end of this topic. Thank you.